Welcome everyone to our second webinar on research participation. Thank you for coming. And please note that we are live and that we are recording this. I am Paola Berberino, the Chief Executive of Alzheimer's Disease International, also known as ADI to some of you. This series of webinars is extremely important to us. We are on a complicated journey to understand the challenges and barriers to clinical trials from a variety of point of views. Our hope is that at the end of this journey, we at ADI have a much clearer idea of what kind of advocacy is needed globally to ensure people with dementia and their families have the best possible chance of participation in clinical trials. We also want to know what would be needed for this participation to be effective. This series has already had an impact. After Eileen, who has dementia, and Douglas, who cares for her, spoke at our last webinar, two companies who are doing pharmaceutical research held internal seminars with their teams to understand how to change their practices to reflect the feedback they had. The fact is, clinical trials are a complex topic, but sometimes it does not take much to remember that we need empathy and care in everything we do, and that small changes matter. We have participants today from 50 countries and 5 continents, and I thank you all for taking the time to join us. This is a live and interactive webinar, and we will ask you in a moment to reveal a little bit more about yourselves. But before that, let me tell you about today. Today, we are approaching the topic from another angle. Are lower and middle income countries participating in clinical trials? And if not, what would it take for them to do so? And therefore give their citizens a chance to take part. We will also explore the experience of clinical trials as seen from the viewpoints of family doctors. I need to thank, before I go any further, the team at ADI, Wendy Widener, Ali Bliss, Jenny McGowan, and Laura DeBass, and Chris Lynch, who have helped put this together. The team at Edelman that provides us technical support, our sponsor Roche, which has enabled us to do these clinical trials webinars, and leading lights on our medical and scientific panel, Serge Gauthier and Alireza Atri, without whose advice and support this also would have not been possible. Before we start, we promised those of you who sent questions that were not answered last time that we would take some of those in the webinar today. And a few of them I will actually answer straight away. One of you asked if the barriers and enablers to clinical trials are only for clinical trials or for any research, for example, research on behavioral intervention, and if ignorance and stigma play a part in those. Our evidence so far is that yes, similar barriers touch every area of research, and that stigma does indeed have a part. Our World Alzheimer report in 2019, which will be published in September, will focus on these issues. So I invite all of you to stay online and keep attention when it's going to get published. Another participant asked if there are early signs of dementia and how to identify them, and could this help in early treatment? Yes, there are early signs, and on our website there is a handy infographic which will tell you what these early signs are and how to recognize them. Timely diagnosis is very important in dementia treatment and can definitely help on a number of levels. There were many more questions, and our panelists will aim to respond to those today, so stay please with us. The wonderful Craig Ritchie is with me here again, and he will introduce you to our great panel in a moment. Craig is chair of the Psychiatry of Aging at Edinburgh University and is director of the Centre for Dementia Prevention. He is also running one of the largest clinical trials in Europe, and we are very fortunate to have him with us today. Craig, over to you.
Thank you very much, Paola. Thanks for the introduction. So it's a great privilege to moderate this webinar. I had the honour of doing the first one, and it's great to see how successful that was, as indexed by actually more people registering for this one than we had at the last one. We're deliberately setting this up for this panel discussion to be a very great dialogue between ourselves and the panel and also the people who've dialed into the webinar. And the way we're going to do that is that you will be able to type in questions as we're going through into the dialogue box on your screen, which we will then pick up and then be able to pass to the panel as we're going through. We only have an hour, but we'll try to get through as many of the questions as we can. What I'd like to do before we go any further is just allow the panel to introduce themselves and tell them a little bit about themselves in terms of their research, their clinical practice, and why they've got involved in this webinar today. So I'm going to start in the room here with Mia, and then pass to Jill, and then Rochelle, Sylvia, and then Elizabeth. So Mia.
Thank you, Craig, and thank you, ADI. It's a great pleasure to be here today. My name is Mia Kivipelto. I'm professor in clinical geriatrics at Karolinska Institute. I'm medical doctor. I'm geriatrician. I'm also the research director for the geriatric clinic, now called Theme Aging at Karolinska University Hospital. I also have a part-time position at Imperial College London. My main research interest has been prevention. I have been running observational studies, and now I am also working more and more with interventions. I have been the PI of the FIN trial. That was the first large randomized control trial, really showing that multi-domain intervention with lifestyle factors can reduce the risk of cognitive impairment. It's very nice to see that the interest is great for this type of interventions. We have launched worldwide fingers, and now we have 15 countries all over the world who are participating there. I'm happy to talk more about that later.
Thanks, Mia. I've got to mention, by the way, for everyone, we are recording this, and that means that in a few weeks' time, once it's been edited and tidied up, we will be able to post this as we did the previous one on the ADI website. So Jill.
Good afternoon, everybody, and thank you to Craig and to ADI. I'm Jill Rasmussen. I'm a clinician based in the UK with a relatively unusual background. Although based in primary care in what we call the NHS, National Health Service, I have a specialised role in primary care in psychiatry, neurology and learning disability called GPs with special interest. But before that, I spent 15 years in the pharmaceutical industry, both on mainland Europe and for 4 years in America. And I've also spent 2 years working for the UK regulatory agency, the MHRA. So I'm very pleased to be with you today to give a perspective on research and also primary care.
Thank you very much, Jill. So can I go to Rochelle? I think we have to unmute you. Oh,
okay, there we go. Hi.
Thank you. Hi.
Good morning, everyone. My name is Rochelle Moore. I'm a research fellow at the Caribbean Institute for Health Research in Jamaica, here at Mona. However, I am from Trinidad and Tobago, so I don't have the Jamaican accent, you might notice. I am also the Assistant Director for Alzheimer's Jamaica here. I have a background in psychology and gerontology, so the big intersection of those two is dementia. I've had the benefit of doing my postgraduate work in London and working with organizations there, and then also working with organizations, both government, NGO, and now academic in the Caribbean. So I've been able to have those different perspectives and experiences coming from high-income countries, a city like London versus countries like Jamaica and Trinidad and Tobago. So that's what I really got excited about this webinar for. I think it's really important to discuss these gaps and really educate ourselves and learn from each other about what's happening.
Fantastic. Thanks very much, Rochelle. Can we move to Colombia, where Sylvia is? Sylvia.
Hi, good morning or good evening, everybody. I'm Sylvia Rios Romagnets. I'm behavioral neurologist, and I represent a group of neuroscience of Antioquia, University of Antioquia. I'm medical director or deputy of Alzheimer's Prevention Initiative in Colombia, and it's our 6 years. We start 6 years of clinical trial and of API. Alzheimer dominant autosomal dominant Alzheimer disease trial with crenezumab. So I'm here to share with you our experience. We started practically from zero, so I'm happy to share with you our experience and also to learn from you. Thank you.
Thank you very much. And last but definitely not least, in Kenya, Elizabeth, do you want to introduce yourselves to the group?
Hi everyone, my name is Elizabeth Mtunga. I'm the CEO and founder of Alzheimer's and Dementia Organization Kenya. I got interested in dementia because my father had dementia, And so initially we did not understand what we were dealing with, and that's what made me want to help other families affected. My area of study is psychology too, and I've also done HR.
So welcome everybody, and one of the things we wanted to do, we've introduced ourselves, so you know who we are. Now obviously we can't go around the several hundred people who are participating to have personal invitations, or personal introductions. But what we did think we could do is we could run a poll. So poll number 1, which Wendy's going to bring up in a second, simply asks the question, it's on the screen. We're interested in learning more about you. Can you tell us, are you a person living with dementia, a family care partner, a researcher? Do you work or volunteer for an Alzheimer's disease or dementia association, a health professional, social care professional? Do you work for industry? Or are you just curious and want to find out more about dementia generally? So we'll just run this poll for a second. It's great fun watching the bars go up. Because we can see that working or volunteering for Alzheimer's is so far winning. In second place, we have, it's winning by all researchers. So, okay, so that's fantastic. So I don't know, people see the results of the polls on their screens as well?
Yes, you tell me when you want me to end it.
Okay, I think we're still having people coming up. There's 110, 111. So I think we've got a good balance here. We've got mainly, I think, people who are working and volunteering for an Alzheimer's Dementia Association, and a very good proportion, 22% of people who are researchers in many pharmaceutical industry as well. It's good to see we've also got people who are just curious about dementia research. So hopefully that we'll get some great questions from all of you. Okay, so what I'm going to do now is we had some questions that were sent in earlier, and before we kicked off, we kind of allocated them, if you like, to some of the panel members. I'm going to ask, first of all, Mia. We had a question, actually 2 questions really, about family history. And both my parents had Alzheimer's. Was a question. What is the risk for me and my siblings? Is there anything we can do to reduce the risk? And a complementary question was, I always thought twins share the same DNA, but how come my mom has Alzheimer's while my aunt doesn't?
Thank you for the good questions. What we have learned, I would say, that Alzheimer's disease is very complex disorder. There are both the genetic factors and environmental factors. And on individual level, it's sometimes very difficult to know how big is the risk, because we all have a special combination of the genes and environmental factors. Our environment, our society today is different what our parents had. There have been changes in the society. We are treating better many of the disorders. So these all factors are there. In general, we can say that, for example, what type of dementia I would say parents are having, what was the age of onset are also important. Younger you are when you get the dementia or Alzheimer, higher is or bigger is the genetic risk. So this is the, and older you get is more also the environmental factors. There is a specific group of Alzheimer called familial Alzheimer, where it's a very strong genetic factors. Then you normally get it when it's in the families. But then you get the disease very early, normally around 40 years, 45 years. So that's a very specific group. And I would say less than 1 or up to 2% of all Alzheimer is this genetic familial Alzheimer. So it's only a small group, and all the rest is the combination of genes and environment. So the answer is, if we can do something, yes, we can. We can always try to reduce the risk. We know that at least 30% of Alzheimer may be related to the environmental modifiable risk factors. We also have new findings from our FINGER trial, which I mentioned, that if you have ApoE4, that is the main genetic risk factor, then this intervention has really clear beneficial effects. So I would say that if you have the family history, it may be extra important to take care of all lifestyle factors. We don't know exactly how much you can reduce the risk, but I think even if you could postpone the onset by some years, that would have a great benefit.
So thanks so much for that, Mia. And just as you were picking up there about modifying risk factors, but at the moment, I think a lot of the balance is towards drugs. There's a lot of treatments that are being sort of proposed for Alzheimer's disease and other types of dementia from a pharmaceutical perspective. And Jill, we did get a nice question about that, saying there's a lot of companies advertising quote unquote wonder tablets that help boost memory. Are they real?
They obviously haven't been subject to the same rigor that we've explored the efficacy and safety, which is really important, of medicines that we use to treat a condition that are approved, and they tell you the plus points and the warnings and the negative points. So as with many things on the high street, the emphasis is more on the plus points rather than the balanced view. However, one can also say some important evidence has come from nutraceuticals, vitamins, and other additives to our diet that have led to a more rigorous study. So things like folic acid, fish oils, vitamin D, which you can buy in the health food shops and on the high street. We are seeing increasing body of evidence to show that some of these have a particular role in certain subtypes of dementia for certain people. But they haven't been fully explored. But it's also really important to realize that many new drugs can come from naturally occurring products. And there are pharmaceutical companies who will then carry that preliminary evidence, hypothesis generating evidence forward into more rigorous research. I would urge anybody participating in a research study, if you are taking any of these over-the-counter or herbal medications, it's important to tell the researchers that you are taking those medications, because there may be interactions and sensitivities.
So thanks, John. And you highlighted in that, and it picks up what Paola was saying in the very beginning, that a lot of the things that are being promoted that might be helpful don't necessarily have a very strong evidence base, and the research hasn't, if you like, taken place to the standards we would like. And I'm just wanting to bring in Rochelle. Clinical trials research in low and middle income countries. There's a question that we got asked from actually someone in Malawi. It says, who can fund research and trials in dementia in low income countries, and how can we attract more funds and competent researchers to work in our country? So that evidence base that we develop around lifestyle interventions against for drugs or nutraceuticals, how can we make sure that's being conducted where the need is maybe greatest? Michelle?
Yeah, so that's a big question, and I'm going to start with the second part of it about how can we attract competent researchers to work in our countries. And I think the question really is, how can we retain competent researchers in our countries? Because as I mentioned, I've trained in London, and that's extremely common, at least in the Caribbean, for persons to train abroad. But the coming back part is the issue. And so that's, I think, an issue for most developing countries, where you do have really excellent skill sets, but they're not staying at home. And that's because of the funding part of the question. Who can fund this research in low-income countries? And as it stands, and all of my research colleagues, we talk about these things all the time because this is the experience that we're working with. As it stands, a lot of the funding comes from international donors, and that's not something that's secure. When you are dependent on most of your funding to come from an external source, there's a lack of security and consistency, and so there's almost a scarcity in terms of who's going to get that and for what. So really, and I know that this is mostly the opinion, and we keep saying it over and over again, is really trying to increase the priority of internal research funding from local governments in these countries. And that's a whole other discussion, and then I'm sure we'll get to about how do we do that. So I think in answer, we really need to make sure that there are secure long-term sources of funding coming from the money that is there. And that would lead to things like secure job roles for people who can actually then stay at home and work in their fields or return home after they study abroad, etc.
So can I ask a supplementary question to that? So for the funding that comes into, when you work in Jamaica, like you said, are the grant holders for those grants, are they within Jamaica, or is this money that's been allocated to, say, the US or the UK? where your collaborators are all the primary beneficiary of the grant, but it is international funding?
It's mostly collaborators. So from the US, the NIH, Global Council Research Fund in the UK, and then there are a couple of locally funded things from like the Ministry of Health on local lifestyle surveys, etc. that we do, but most of it is external. So there is a big part of our work is finding grants and trying to secure that resource.
Rochelle, I think you set a challenge for us all 20 minutes into the webinar to try and encourage grant holding and funding to be internal, as you say, within countries. So it's a very nice segue actually to Sylvia, who's obviously working in Colombia on the API study. The question actually came. The question actually came from Malawi. Is what can be done to shift the trend so that research and trials on dementia take place in low-income countries? How can we make sure outcomes are implemented in these countries? So two parts to the question. Number one is how can we make sure the research is actually conducted in these countries? Secondly, a problem we all face, how do you get those research findings into practice in these countries? Sylvia.
Well, it's very good questions, very complicated. The first step, what we think as representing the neuroscience group of Antioch, is to identify the barriers, the main barriers which each country has, because there can be differences also. No, according to cultural, social, political differences. No, identify the main barriers. For example, what kind of healthcare you have in your country, what kind of stigma or other social, political, cultural differences. No, and always find the start point and work proactively, not waiting that somebody will come to you and offer, let's do the research. No, start in your country to look what population do you have and start to build like a type of registry. I can give you the example what's happened in Colombia. Dr. Lopera, Francisco Lopera, who is a principal investigator who found our group and who first identified the families with familiar Alzheimer's disease. No, so he started from zero in 1984, I think, and he found this, identified the family, and now gradually with other doctors and students and nurses start to build a team and at the same time expand these families, no, assessing more and more patients and family members, healthy members. And like that, he started a small registry. And then the registry start to grow, and thanks to collaborative work with external groups and also internal local groups, the registry practically now is, we have like 6,000, almost 6,000 members at this registry, which includes patients and their family members, no? And of those are practically 1,000 carriers with the same disease. So, and how we build this registry is very important, because from registry you can develop different types of studies, not only clinical trials. No, clinical trials are very important, the prevention trials are very important, but also you can do other research, which is also important, cognitive clinical descriptions of the population, biomarkers, and other type of research. So how which strategy you can use to build this type of registry? You have to build your interdisciplinary team, which can go not only work locally, but go also outside of the small towns and access at home participants, so patients and their family. You can also build like a social plan, which is a type of workshops or support groups for these families, when you can build relationship and trust. And also the most important, also educate the people. What is dementia? What is Alzheimer's disease? What is familiar disease? Why is so important to be part of the registry? Why is important to participate in research? You work with the stigma, no, or some different cultural, social culture differences. So I think the most first step is to start to work, identify the barriers in your country and build the registry, and then find maybe collaborative support and locally and internationally.
So thank you so much. Because I think what I picked up there from you really complemented what Rochelle was saying. So Rochelle was talking about retaining the researchers to be able to conduct the research. What you were talking about was, if you like, finding the people who will participate in the research to generate the knowledge and such like. And one of the things you mentioned there was stigma. And it actually dovetails really nicely with the question we actually got from Kenya, which is, and I'm going to ask Elizabeth to pick this one up, is how can low and middle income countries come to par or come up to the same level, if you like, with developed income, higher income countries, if you like, in terms of knowledge of dementia in order to demystify it. So it's a question very much about how can we demystify dementia in certain other parts of the world, maybe to the same way we've achieved it, if you like, in higher income countries. Elizabeth.
One of the things I think that is very critical in demystifying dementia is talking about it, creating awareness about it, and getting the correct information. Because once we don't have the correct information, then we do not know what we are dealing with. And a lot of times, especially in Africa, we are fond of hiding and not speaking about what's going on, especially when it comes to dementia, because there are many other factors and things that are said that make you want to almost hide your loved one who has dementia. So I think by speaking out, we will be contributing to less stigma and discrimination. But when there's no awareness, you don't know what you're dealing with, and thus you are prone to keeping quiet. And I think, because the question asks, how can low and middle income countries come to par with developed income countries? It's because the developed countries have been speaking about it. And if we check now, they are at the stage of end Alzheimer's, while we in Africa are at the stage of even trying to understand what dementia is. So I think by speaking out and just telling everybody about it, let everybody know what you're dealing with, it will actually demystify the issues.
Thank you so much, Elizabeth. I'm just aware that there are some questions coming through, so please type them in, and we'll pick them up and we'll share them with the panel in a moment. But I just wonder if it's worthwhile going to a poll now that we've heard some answers to some of the questions that were sent in earlier. And I really like poll number 2 as a fire engine goes by here in London. You all hear all that. Are you ready with poll 2, Wendy? I should have given you a 5-second warning. Poll 2 is, what sort of dementia research or clinical trials do we really want? There's no right answer to this, by the way. But if you can pick maybe your favorite one. Do you think we should be doing clinical trials of pharmaceuticals? Should we be doing clinical trials of psychosocial interventions? Should we be taking multi-domain approaches to interventions? The finger study, for instance. Do we be doing biomarker research to detect disease at an earlier stage? Health economics, cost analyses, epidemiological study about the incidence and prevalence, new therapies and innovation. I don't really think and say I don't know. Never mind. And then other. So I don't want to allocate yourself to one of those groups, and we'll see what type of research from an ADI perspective we should be amplifying and seeking to encourage, so that Rochelle can get millions of dollars of grants into Jamaica around these things. So it looks like it's actually a really interesting spread. Everything seems to be quite important, but I think the one that's winning at the moment, yeah, I think Mia's actually voting. She's voting under the table as we speak here for multi. I think we've got, what we do obviously have is an incredibly well-informed group of delegates, because I think the evidence, the evidence on multi-domain approaches seems to be the strongest moving forward. Interestingly, the clinical trials of specific pharmaceutical interventions is losing out to multi-domain psychosocial interventions. So that's really, really interesting take-home message. She talks a little bit more about maybe prevention research as well. So that's really, really good. Have we got many questions from the...
We have some comments. We can continue the question from before, but I wanted to take one of the points that Rochelle had made and one from Sylvia, and just make a general comment. As you know, part of the series is the possibility for us to formulate better thinking around clinical trials, and what is an organization like ADI that has an opportunity to advocate globally can then take home from this. And it was very interesting what Rochelle said about governments, because there is a whole social impact. If researchers with talent spend time usually studying abroad, don't return home and employ those talents, if the government don't nurture an environment for research, and let's be clear, this doesn't happen just in lower and middle income country. I was in Italy recently, and researchers at the Center of Research of Italy, the central research body, were on strike because there were no funding for research. So if we don't nurture research at its basis, then it's very difficult. And this is a job for governments, and ADI will continue to advocate for 1% of the societal cost of Alzheimer and dementia to be devoted to research. This is exactly the problem. You have to create a social environment which is fertile for research. The other point I wanted to pick up from Sylvia was around the importance of setting up registries. That's the first thing you said. The way that you start this is by understanding what is the population that you can research on. And I think in the first webinar of the series, those of you that listened to that, Piers Notting, who was speaking about this issue, just emphasized that. And I think this point about dementia registries, which is actually quite complex and quite nuanced, is something that we may well want to bring forward in another webinar, because the non-sharing of this data or the non-collecting of this data actually at source are starting to look like one of the big stumbling blocks to us really understand dementia as a global phenomenon, because this is not confined to one country or another country. Every country is part of this giant issue which is trying to solve the dementia conundrum. So thank you very much, Craig. And I think we may have some other questions, or you can go back to the original sheet because we had plenty to start.
Just as I'm collating those, and Paolo, you mentioned government, and there obviously is a Prime Minister's challenge in the UK, and it's been picked up from other people. And Kate, Timothy, somebody from the UK asked the question, said that the Dementia Development Fund, the UK government, if you like, and World Dementia Council has said they're committed to finding a disease-modifying, for me, by the way, a disease-modifying treatment by 2025. That's only 6 years away. How close are they? And how realistic is this time frame? No pressure, yeah.
No pressure. And this is a challenging question, and we all know that it has been so difficult to find the new drugs. The last drug on the market came more than 15 years ago, and there have been so many failures, more than 200. So it has been difficult, but I'm kind of optimistic. I don't dare to say that it's up to 6 years, but in the future. I don't think we may have one magic pill, but I think we are moving from the complexity to more the personalized medicine, maybe understanding about the subtypes of Alzheimer, a little bit like the cancer field, that we find different cocktails, different drugs that can be used for different subtypes of Alzheimer. So there are a lot of trials ongoing. We are starting much earlier. We are using the adaptive design like in EPAR. So there are a lot of new initiatives, which I think is very much needed. It's really the collaboration between academia, industry, different stakeholders. So that I think is the key. And here I see the hope. We work together, we learn from each other. I also see, even I mentioned that the multi-domain is of course what I believe, but I don't think it's like lifestyle or drugs. What I think may be the solution is the combination. We combine lifestyle with different drugs. There may be also some drugs already on the market that can be used for some subgroups. So I think there will be, hopefully in the close future, better treatment options for different subjects.
Thank you very much. So do you think 6 years?
6 years, I would hope that we could get better recipe that we could offer really for the patients better ways to treat them, starting earlier. And I think this comes also for low and middle income countries. You mentioned about the challenges there. I think building the infrastructure and starting the lifestyle trials in these countries, I see it now with the worldwide fingers. There are many countries from low middle income countries who are joining. And you also mentioned the importance of registers. For example, in India, they did not start immediately with the trial, but they wanted first to make the survey to really understand the risk factor levels and the scales that should be used. So we need to do it in different steps.
So Jill wanted to mention something about that question as well, but I'm just aware that the people who are on the webinar from Jamaica, Colombia, and Kenya, if you want to chip in, please just raise your hand and compliment or argue or disagree with me as you see fit. But Jill, you had a particular comment about this.
Yeah, I just wanted to pick up, you mentioned obviously multi-domain interventions. And also, I think it's up to scientists and researchers to have a realistic picture of dementia as a complex disorder. So we have oxidative stress, we have inflammatory processes, and it's much more than just amyloid and tau and synuclein. And we need to be thinking of it, the picture of it, as a complex disorder, and that one size is not going to fit all, and we need the right combination, just as with other clinical conditions, asthma or diabetes. And it's going to be multi-therapies that are going to help us.
So Jill's advocating for personalised medicine, which is fantastic. So can I maybe bring in? I'm going to pick on you actually, Sylvia. 2025. I mean, you're very much involved, as you said, with the I can never say crenezumab study in the familial AD. Do you think 2025 is a realistic timeline for having disease-modifying therapies on the market?
Well, it's a complex situation. Yes. Our study, we're planning to end by 22. So, and as you know, last week we have a news that practically all study with crenezumab was closed, but that was closed for sporadic Alzheimer's disease. So all sites are closed. Only one study practically who is now active is our study, no? There is a difference. It's why we're not closed. So we'll continue. We're hoping to finish and have some results by 22. So our population is different. It's genetic, it's familial Alzheimer's disease. And the very important point is to start as early as possible. So we practically start to treat people, unimpaired people, cognitively unimpaired, practically like kind of healthy people, no? So it's very important to start before all this changes in the brain happens, no? Or even they happen, they're not so severe like in symptomatic Alzheimer's disease. So we're hoping that difference, this is a real prevention trial and genetic population, and all the data where we're collecting the biomarkers and we're observing how the disease develops, even is not a typical sporadic Alzheimer's disease, because there are some differences between familiar and sporadic. We think this type of the study, prevention studies, they can contribute in general about the knowledge about Alzheimer's disease. And we hope, and also will be positive, we hope, by 22. But even the negative studies, even the negative clinical trial is disappointing. It's causing a lot of grieving sensation in participants when this clinical trial don't work. But I think it's important to understand for us, for researchers, and for participants and caregiver, even the negative results are the results. So each clinical trial, each study done is also contributed with some knowledge and some results. And that helped together to build better clinical trial, maybe to find another molecular or better protocol or better like different conditions, no? So I think overall, people don't have to be discouraged, even there are not positive results all the time. We still worry we will not step by step, and we eventually will find the solution. But I am optimistic, and answering your question, I'm hoping by 25 for sure we'll have some molecular or maybe combination of intervention, not only hoping for medication, maybe the lifestyle combination with medication. All these factors together will change, at least maybe delay some onset of disease. Mm-hmm.
And I personally share your optimism, and obviously wish you every success with your study, the API study. And I think there's a question here from a friend of mine. I won't name any names, but from London School of Economics, who's asking a little bit about research into the way we set up healthcare systems, because I think one of the things that we find, dare say, slightly frustrating is that sometimes it's quite difficult to get research findings into practice. And I'm going to ask Rochelle and Elizabeth to comment on this. But let's assume that we get a multimodal intervention that proves to be effective, a complementary pharmaceutical intervention. Are our healthcare systems, do they need to be researched upon now to prepare ourselves for breakthroughs in therapies in the not too distant future? So in the Caribbean, in Jamaica, and then over to you, Elizabeth, for Kenya. Rochelle. Wait on mute, Rochelle, sorry.
Okay, yeah.
Thank you. Yay!
That's a great point. And coming off of as well what Sylvia was saying, for us here, for example, I'm a non-clinical person. I don't have a clinical background, so I'm speaking from that perspective. But I'm working on a really great, amazing dementia project right now called STRIDE, Strengthening Responses to Dementia in Developing Countries. Jamaica is one of the participating countries, as is Kenya. So Liz is my colleague on that end. And AGI, of course, is an extremely important partner on that project. But that's something that we've been asking ourselves, because the project is multi-pronged. So there's some work on cost analysis, there's some work on prevalence, there's some work on stigma reduction. And a big part of trying to figure out basically the feasibility and viability of the work that we're doing in terms of actually making an impact, which is what all research really wants to do. We've really tried to prioritize engaging our stakeholders on the ground. So Ministry of Health, PAHO, Pan American Health Organization, etc. That's been a big part of our work, and we've done that formally and on our own as a team. But in terms of getting the health systems where those are to actually implement the findings, I think it comes down to the idea of implementation science, right? What we know about how does this work? Because in reality, especially in developing countries, Liz was saying before, you know, we're quite far behind in this whole concept of dementia sometimes, in terms of what it is and you know, that mystification around it. But there's also some confusion, as Sylvia alluded to, about what research is and the expectations coming out of research. And so trying to really understand that in reality, these things take years and years and years and years to make an impact. And trying to then look on the implementation side through not just the health systems and their readiness, but also the research side of it. How realistic are these outcomes to then carry on into the real world? How likely is that to work within the time allotted? And so that sustainability for STRIDE is a big part of our work. You know, even after the project ends, trying to prepare the systems around us, which is why one of the big outcomes is around policy within the health system.
Sure.
So I think that's something that is so, it's sometimes like an afterthought, but it absolutely should not be. It should be the big part of the thought process going in. How is this going to end up within the health systems that we're working in this country?
And I do wonder, before turning to Elizabeth, that, you know, our audience said they wanted to prioritise multi-domain interventions, psychosocial interventions, there's an over pharmaceutical. And I do actually sometimes wonder if the implementation of multi-domain interventions might, dare say, be easier, especially all over the world, because the risk factor modification might be an easier implementation than necessarily very costly pharmaceuticals with biomarker testing, etc. So, Elizabeth, the implementation of findings of research into clinical practice or healthcare systems, and working out what those healthcare systems need to do to change. What's your perspective from Kenya on that?
Like I said, we are still at the nascent stages of understanding dementia, but it is a very good thought, because I am confident that once we understand what dementia is, then we move to the next level. But at the moment, like Rochelle just mentioned, we are also part of STRIDE. And one of the things actually Kenya is working on is an anti-stigma toolkit, so that we can start having this conversation with people, even in the Ministry of Health, because even medical personnel, some of them even do not understand what they're dealing with at the moment when you have somebody with dementia coming to see you. So I am impressed that we are talking about 2025 on your end, that we will be having these systems in place. We are hoping we can just jump into the bandwagon and be part of it. But for us, the reality on the ground is we are not there yet, but we're not going to give up hope. I think the conversations have started, and it is going to, there's a great future ahead, I believe so.
So Elizabeth, can you do me a favour? If you get a system set up by 2025 in Kenya, can you come over to Scotland and help me? Okay, that'd be fantastic. There's a couple of questions here that Paula, I think, would be best to answer. Once, what can one do to help people with dementia and mild cognitive impairment living in settings without access to specialist medical care? And a second one, which is maybe slightly unrelated, but is there someone living with dementia on the panel? If not, why not? So, do you want to take those, Paula?
Yeah, I'll take both of them. So, at first, I take the one about why don't we have a person with dementia on this panel? Now, as I said at the very beginning, you have to look at this series as a continuum. So, we kicked off the series last time with Eileen and Douglas giving us the perspective of a person with dementia and their carer. They actually framed the entire debate, which is then now supporting these further panels. And there are other people that we haven't had on the panel yet, which are equally important in the spectrum of what we are trying to discuss. For example, we haven't had a regulator yet, and yet we know that access to clinical trial often depends so much from regulation. So we will have people with dementia again on this panel, but you really do need to bear with us and take this series in its entirety. It's not just about one webinar, it's about the continuity of the webinars. And that's why all of the webinars are available on the internet. So what we discussed last time is very much part of what we are discussing this time. And this time we wanted to give a lot of relevance to lower and middle income countries. And we wanted to see the perspective of family doctors, which last time we just could not represent, and that form such an important key point of entry for every person, which leads me to the second question, which is what can we do to help people with mild cognitive impairment living in settings without access to specialist medical care? Well, it's not just access to specialist medical care, sometimes it's access to any care. So in many of the countries that we see, access to primary doctors even, it's limited. There are resources that can help people with mild cognitive impairment and their families to start understanding more around what can they do to create spaces, to create areas that people can work with better in order to improve the quality of life of people with dementia and of their families. And this is one of those topics that we focus on at ADI. It's not about clinical trials, it's about environmental improvement, and it's about better understanding. And that also comes with less stigma and more awareness raising, which is what Elizabeth was pointing out. So at the end of this webinar, we will send a link to some resources which are available. And in the future, do follow ADI because there is a lot of other information that we put out there, which is exactly on this topic. Thank you.
Thanks, Paula. So we've got 11 minutes left. I'm going to have in the room, Mia's got a question here from Mexico. She's going to save my voice and read it out herself and answer it. Jill's got a question. You're going to read it out too and answer it. That's going to take 4 minutes between the two of you. Then we're going to go back to the poll, because I love repeating that poll, see if we've changed anyone's mind, changed anyone to don't know somewhere else. And then I'll prepare the panel. I'm going to ask you to sum up by telling me what the one greatest challenge you think is in terms of undertaking clinical research or undertaking research in dementia. But finishing on positive, the one thing that gives you the greatest hope. Okay, so those are the questions I want you to finish on to summarize. So Mia, then Jill, then Nicole, then all five of you, 2 questions, and that'll be us at 4 o'clock.
Yes.
5 o'clock.
Thank you. So the question is here that there is a lot of research in laboratories, and it's important what kind of research is outside the laboratories. For example, non-pharmacological interventions, and what are the most novel investigations that are carried out. So indeed, there are a lot of research on non-pharmacological interventions, both using observational, epidemiological studies and interventions. I would like to highlight 5 different non-pharmacological topics: physical activity, diet, cognitive activity or cognitive stimulation, vascular risk factors, and psychosocial risk factors. For all of these, there are a lot of also basic science. You mentioned about the other mechanisms like inflammation, oxidative stress, cognitive research. So there are a lot of interesting research going on, which I think is important. And also, I would say as a one topic, psychosocial factors, sleep, stress, depression have been getting increasing interest, and I think is very important. One more example about diet and these mechanisms. Microbiome is just one example about a new area that has been now linked with the brain. So I think there's very interesting new areas what we should study. One more example from the interventions, there was recently, just last week, a week before, the results from the Sprint Mind study showing that blood pressure medication could reduce the risk of MCI and dementia. I don't know if we can call it disease-modifying drug, but we have something we can use, hopefully, in the close future. And final point is, from my point of view, the implementation that was mentioned. That is also a type of research, implementation research. What is needed that we can start using the results? In general, there are studies that it takes 15 to 17 years to implement our results. I hope it does not need to take as long to implement some of these healthy lifestyle features. 2 minutes.
Perfect. I was watching the clock and you were spot on. So Jill, 2 minutes. 2 minutes.
The question is, whilst Alzheimer's is the most spoken about and researched in clinical trials, why is there less discussion about diagnosis and research of the other subtypes of dementias? Well, as probably most of you know, Alzheimer's is the most prevalent of the dementias, approximately 2/3 of cases. And there's been a lot of funding and important funding, and there's been a lot of focus of the socio-economic benefits of focusing on Alzheimer's research because of its highest prevalence of the subtypes of dementias. But we've also realized if we want disease-modifying therapies that disease process of dementia starts 10, 20 years before clinical symptoms appear. And we need to be identifying people at risk of all subtypes of dementias. So we're seeing increasing evidence, as Mia has indicated, on looking at risk factors. And that brings me to a point we spoke earlier about registries. And in primary care, we have registries in the UK of people with at-risk conditions, whether it's diabetes, stroke, hypertension, cardiovascular disease. We don't have a Parkinson's disease register, but 1/3 of people with Parkinson's disease will develop dementias. We're also getting a greater understanding of the other subtypes of dementia and maybe certain overlap features. So for instance, the vascular basis of Alzheimer's disease and the importance, as Mia was highlighting from the Sprint study, about controlling blood pressure. We're also seeing that from other studies, something called the Cognitive Function and Aging Study. There was a Cognitive Functional CFAS Study 1 and a CFAS Study 2. And what they're showing from that study is that the prevalence of dementia is actually flattening off. That doesn't mean that the number of people in the world are going to decrease with dementia because there's more people living longer. But what it means is we have been doing something in the UK that coincided with monitoring blood pressure, with managing cholesterol and cardiovascular disease in primary care. And I think that we need to be realizing that a lot of the people we need to be recruiting for the trials to look at disease modification are from primary care, the people at risk, because general screening for dementia is not what we want to do. The other thing I'd just like to say is there is research ongoing. We need more symptomatic treatments. And I've been part of a group recently that's been looking at criteria for apathy. There are criteria coming forward, or discussions about criteria for psychosis and dementia. All these are important areas that impact on quality of life of patients and carers.
So I think that's a really good point to end and emphasise. We've talked a lot today about treatment and interventions which might prevent dementia. We should not forget people living with dementia, and better, be they drug or non-pharmacological therapy. So thank Jill for reminding us of that. So we're going to go to that poll again, poll number 2. I should have written down the results of the previous one and done a quick I-squared in the back of the envelope. So had significant impact during the last 40 minutes. And as that poll's running, I want each of you to think about the one greatest challenge and the one greatest hope you have for the future. So if we can vote again about, if you can remember your question, your previous answer, that would be good as well. But let's see if we've changed any opinions here. So what do you think the priority should be for global dementia research? Now, Mia, you're going to remember what it was for multi-domain. It was 43% last time.
Different ones were 31 and 32.
Which were, sorry?
31 and 32,
So
psychosocial.
Was 31.
And epidemiology was 30.
Clinical trials looks like it's a drop. So the good people who are here, 20% of the attendees were from the pharmaceutical industry, and only 12% were voting for research in pharmaceuticals. So it's an anonymous poll, thank goodness. But I do think we have maybe moved opinion away towards your multi-domain interventions, and that's fantastic. Anyway. Okay, thanks very much. So I'm going to go around. I'm going to start with Elizabeth, then Rochelle, then Sylvia, then Jill, and then Mia. One, because we've only got 4 minutes left, the one greatest challenge to implementing research and the one thing that gives you most hope. So, Elizabeth.
Okay, for me, one of the things where I also got very interested in this is because we have not had any clinical trials in Kenya at all, and we hadn't even known. We've heard of them, but we've never known of them. So for me, it was a bit frustrating to even see people who have benefited from that. So that was a bit frustrating. But hope is this conversation is going forward, and I think it will be better as we go along.
Rochelle, what's your biggest challenge and your greatest hope? And don't mention the cricket.
And don't mention the
So your greatest challenge and your biggest hope.
So, the key word in low and middle income countries is income. So I think one of the greatest challenges we have is the funding and resources, which is related to another huge challenge, which is understanding, as Paolo was saying, why research should be a priority investment, and understanding that for governments and communities. But my greatest hope comes from the conversation that's been really taking off, especially in Jamaica and the Caribbean, around dementia. The recent work that we've been doing with Stride, people have been sharing, they've been willing to come forward, they've been willing to be vulnerable, and that's a shift that we're seeing culturally that's really, really great.
Fantastic. Sylvia, challenge and hope.
The challenge was to recruit the people, interested people in the clinical trials and in general for research in our group, and to maintain through the time, because one thing is to recruit, but another point very important of research in general is the adherence retention in any study in Alzheimer's disease or dementia. So this is the big challenge for us as a research group. And the hope that we will somehow find solution for the families who suffer with Alzheimer's disease in general, for all people in the world, to find some solution. Can be a drug or can be any intervention. So we're hoping we will find this as soon as possible.
Jill.
I think the biggest challenge is going to be people's access to these new treatments, whether it's multi-domain or new therapies, and appropriate pricing and health systems in place to make sure the right people get the right treatments. My biggest hope is that we will learn from collaborations like ADDI and other collaborations like Mia's doing, to share data and learn from those data, and that we have the right parameters in those data to be able to make and work to draw appropriate conclusions for people across the world.
Biggest challenge in our countries is that the care is in silos, it's too late. So if we want to focus on prevention, we need to have something more. Biggest hope, I think, is in, I would say, prevention, both pharmacological and non-pharmacological, and this combination and the joint teamwork. We need to work jointly to get there, and I see that is happening, so that's mine.
So I'm going to pass to Paolo for final comments. My greatest challenge? My greatest challenge is getting research into practice. My greatest hope is we have another one of these webinars in a few weeks' time. Okay? Paolo, final words.
The last few words. So I hope you enjoyed today, and thank you for following us. Thank you for inundating us with questions. We've taken a few. There are a few more, and we will take them either after the webinar or at the next webinar. Now, stay with us. The next webinar is on the 10th of May, and we will tackle this issue from a completely different angle yet. So I would invite you to register your email with us, because otherwise you will not hear about it. So make sure that you get on our mailing list so that you can hear about it. Thank you to our wonderful panelists. Thank you all of you, and thank you for my wonderful co-chair for doing another fabulous moderation of a complex live debate. Thank you so much.
Bye. Bye.